This is the second lecture of neonatal jaundice, and in this lecture we talk about hemolytic disease of a newborn. In this lecture we talk about erythroblastosis fetalis, explore the pathogenesis and pathophysiology of hemolysis due to Rh and ABO incompatibility, distinguish the clinical finding of cases of erythroblastosis fetalis, and judge and be able for diagnosis all type of blood group. Now, hemolytic disease of a newborn was the most serious cause of indirect hyperbilirubinemia that may be associated with severe anemia. It was because of a blood group incompatibility between mother and infant, which may be due to passage of maternal antibody against fetal RBC leading to hemolysis. It is either Rh incompatibility, which is the most serious, and ABO incompatibility, which is the most common, and subgroup incompatibility. Now, the pathogenesis and pathophysiology of hemolytic disease of Rh incompatibility. Each human being regarded his blood group as positive or negative. We mean by positive when we say A positive or O positive. By positive we mean there is an antigen that is present in the RBC. This antigen, either it is C, D, E, C small, C, E small. The most common antigen is D antigen, while a human being that does not have this antigen called Rh negative. So when any Rh negative person exposed to Rh positive blood, it will start to develop antibody, which is called anti-D. Now here, regarding Rh negative mother, when she is getting pregnant with Rh positive baby, this is an Rh negative mother. She does not have any antigen, and the baby have an antigen because it is positive. Blood may go from baby to the mother through fetal-maternal transfusion during a pregnancy, abortion, or labor. So the RHR antigen will pass from the baby to the mother, during the first pregnancy, Rh pregnancy, lead to sensitization and formation of antibody or anti-Rh antibody, which is IgM. The antibody that's formed by the mother. These antibody, at the beginning, it is of IgM type that cannot cross the placenta barrier. Now, pregnancy at this time is usually unaffected, but within 6 weeks to 6 months, there will be formation of IgG antibody that become detectable, and these IgG antibody can crossing the placenta in the second pregnancy. These antibody will cross the placenta, again go back to the baby. So it will cause agglutination and destruction of fetal RBC that may lead to hemolysis and jaundice. That's why hemolytic disease of Rh incompatibility usually occur in the second baby and rarely occur in the first baby because transfusion of Rh positive fetal blood to Rh negative mother during fetal maternal transfusion tend to occur near delivery. That is too late for the mother to become sensitized and form IgG antibody that need a time and transmitted to her infant, which is usually need a time to occur. But when she gets pregnant with the second Rh positive baby, the baby will get the disease. Now, it will occur in the first baby rarely when the mother previously sensitized by receiving Rh positive blood by transfusion for some reason or another, or when she previously has abortion of Rh positive baby with no treatment by NTD. Once sensitization occur and development of the disease, the severity tend to be more with successive pregnancy. When IgG antibody cross the placenta to fetal blood, causing agglutination and destruction of fetal RBC, causing hemolysis, anemia, which can lead to compensatory hyperplasia of erythropoietic tissue, leading to massive enlargement of the liver and spleen. Also, profound anemia results in pallor, sign of cardiac decompensation, cardiomegaly, and respiratory distress in addition to circulatory collapse. Also, it may be associated with edema, ascites, and massive anasarca develop in severe cases that is due to anemia, reduction in the albumin, which is partly the result of hepatic congestion and hepatic dysfunction and heart failure. This clinical picture of excessive abnormal fluid in two or more fetal compartments like skin, pleura, pleural fusion, pericardial fusion, placenta, peritoneum, amniotic fluid, term hydrops fetalis. The incidence of hemolytic disease of Rh incompatibility usually it is low because mother not always get Rh positive baby. It may get Rh negative baby, so there will be no sensitization. 50% of a pregnancy develop fetal-maternal transfusion. Capacity of the Rh negative mother to form antibody is variable, so it may be a week. If ABO incompatibility presence in association with Rh incompatibility may be partially protected against sensitization by removal of Rh positive cell from circulation by NTA or NTB, which is IgM that not cross the placenta. Now, antenatal diagnosis of Rh incompatibility or erythroplastosis fetalis when we have a pregnant Rh negative woman with possible sensitization by previous blood transfusion or previous abortion or pregnancy. Mother who has previously pregnant with Rh positive baby, abort Rh positive baby, and this is the second pregnancy, we should do parent blood group and Rh tested for potential incompatibility. Also, we do fetal blood group. If we suspect the case, we do fetal blood group and Rh from fetal DNA, fetal cell from maternal circulation. Then measure the maternal NTD antibody. Here we can see if the mother has the antibody, so measure the maternal antibody, which is of IgG, in the 12 to 16 week of gestation, 28 week to 32 week of gestation, and 36 week of gestation. So, if there is blood group incompatibility and there is sensitization by the presence of the antibody, now the severity, next we have to assess the severity of fetal disease, because here we confirmed affection. Now here we can see the severity of fetal disease assessed by real-time ultrasound, Doppler ultrasound, percutaneous umbilical blood sampling, and previously used immunocentesis, which are now it is rarely used. Ultrasound and Doppler ultrasound. Doppler ultrasound, we assess fetal distress by demonstration increased vascular resistance in the fetal artery, especially middle cerebral artery in fetus, without eye drops, with moderate to severe anemia, can be detected non-invasively by demonstration of increase in the peak velocity of systolic blood flow in the middle cerebral artery. The velocity of blood flow correlates with the severity of the anemia and therefore can be used for assessment. Also, ultrasound for diagnosis of intrauterine hydrops. Early findings are organomegaly, liver, spleen, heart, and double bowel sign, bowel edema, placental thickening, polyhydramnios, ascites, pleural, pericardial effusion, and then skin and scalp edema. Also, fetal well-being by biophysical profile findings. All these to assess the severity of. Also, we can do percutaneous umbilical blood sampling, which is done if Doppler and real-time ultrasound findings suggest that the fetus has moderate to severe anemia. Per umbilicus blood sampling is performed to determine fetal hemoglobin level and to transfuse packed RBC into fetus with serious fetal anemia, hematocrit less than 30%, who are immature and not suitable for delivery. When the fetus has low hemoglobin and he is still immature, not suitable for delivery, we have to decide to give him a blood to keep the baby intranatally. Amniocentesis was the classical method for assisting fetal hemolysis by measuring optical density of amniotic fluid for determination of bilirubin level. However, amniocentesis is invasive and risky to both fetus and the mother. Doppler measurement of the peak velocity of the systolic blood flow in the middle cerebral artery has essentially replaced the amniocentesis. Now, the clinical manifestation of erythroblastosis fetalis or hemolytic disease of RH incompatibility is various from mild to severe. So it is either develop only lab evidence of mild hemolysis in 15% of the cases, or more with feature of jaundice of anemia, or more severe when the patient develop in addition to anemia and jaundice, hepatosplenomegaly. The jaundice may be present at birth or may be absent at birth and rapidly rise within the first 24 hours and may lead to kernicterus, sometime appear after the jaundice appear after the first 24 hours. In more severe cases, where there is hydrops fetalis in which there is edema, massive anasarca, pleural effusion, pericardial effusion, in addition to hepatosplenomegaly, pallor, and jaundice. This may be also associated with heart failure, circulatory collapse. So the patient with hydrops fetalis may be present with intrauterine death or died shortly after birth because of respiratory distress and birth asphyxia due to heart failure, pulmonary edema, and bilateral pleural effusion. This is a case of hydrops fetalis. You can see the massive edema. This is dead intrauterine dead baby, and this is baby born with massive anasarca. You can see severe buffness of the face, leg swellings, massive abdominal distension. Some patients may have hepatic dysfunction and hypoalbuminemia. In others, there may be hypoglycemia, which may be because of hyperinsulinemia or pancreatic islet hypertrophy. In severe cases, there may be petechiae purpura because of thrombocytopenia due to decreased bone marrow production or DIC. Now, for the postnatal diagnosis, an Rh-negative pregnant woman with history of sensitization by abortion, pregnancy, previous blood transfusion, we should suspect the case and should aspirate cord blood at delivery room or blood from infant present to you later and sent for blood group and Rh. TSV, that is usually 3 to 5 milligrams at birth, may be rapidly increased within the first 6 hours, or very high since birth, or it rises in the first day or later on. Complete blood count, retics count, blood smear usually show anemia, increase in reticulocyte count with polychromasia, also increase in nucleated RBC. This is a feature of hemolysis. White BC usually normal, platelet may be decreases in severe cases. Also, we have to send direct Coombs test or direct antiglobulin test, usually strongly positive and may stay for a few days to several months. When there is a sign of hemolysis, low hemoglobin and high reticulocyte count with other feature of hemolysis, with negative direct Coombs test, we should think of avian compatibility that may be either negative or weak to moderate positive, the Coombs test in avian compatibility, or non-immune causes of hemolytic disease as G6PD, pyruvate kinase deficiency, spherocytosis, and so on. Now, treatment of unborn infant intranatally if the fetus with hydrops or fetal anemia and hematocrit of less than 30% with pulmonary immaturity or fetus less than 35 to 37 weeks of gestation, so we give him intrauterine transfusion with packed RBC by intravascular umbilical vein transfusion is the preferred treatment, although although intrauterine transfusion into the fetal peritoneal cavity is also effective. So, when there is severe anemia, hematocrit less than 30% with pulmonary immaturity, and gestation less than 35 to 37 weeks of gestation, so we have to preserve the baby by giving him intrauterine transfusion. While when the baby was more than 35 to 37 weeks of gestation with pulmonary maturity and severely affected, we have to induce delivery as the preferred method of management. Treatment of unborn infant is still the blood transfusion intranatally should be packed O negative cross-match against the mother serum. CMV negative and leukocyte reduced to reduce the risk of allergy and non-hemolytic reaction, and irradiate blood to avoid transfusion associated graft versus host disease. Transfusion should be achieved a post-transfusion hematocrit of 45 to 55%, can be repeated every 3 to 5 weeks. When the baby 35 or 37 weeks of gestation with pulmonary maturity and severely affected, induction of delivery should be done. Birth of newborn infant should be attained by pediatrician. Resuscitation must be ready. Also, fresh or negative blood cross-match with the mother serum should be prepared before delivery. If a clinical sign of severe hemolytic anemia or hydrocephalus hepatosplenomegaly evident at birth and may have severe respiratory distress or birth asphyxia, so we may need to do resuscitation by endotracheal tube section, oxygen, and ambubag with other supportive measures. Temperature stabilization, correction of acidosis. At this time also may need exchange transfusion or blood transfusion, small shoot of packed RBC according to state of the infant. Also, patient may sometime need volume expander during resuscitation. Now, prevention of RHI isoimmunization, it is done by prevention sensitization of a pregnant Rh negative woman by giving her human anti-D globulin, which combine with and eliminate Rh positive fetal RBC that pass to maternal circulation, thus prevent sensitization. It is given at 28 to 32 weeks of gestation, and also given within 72 hours of delivery, should be given after each pregnancy of Rh positive baby. Also given within 72 hours of abortion, delivery of ectopic pregnancy, amniocentesis, abdominal trauma in pregnancy, chorionic villus biopsy, and transplacental hemorrhage. Also, we have to prevent exposure of Rh negative mother to Rh positive antigen through any Rh positive blood transfusion. So, the prevention by giving anti-D at 28 to 32 weeks of gestation and within 72 hours of delivery, abortion, and so on. Regarding ABO incompatibility, it is more common and usually results in milder disease or milder hemolytic anemia than Rh incompatibility. The cause is reaction of maternal anti-A or anti-B antibody to A or B antigen in the fetal RBC or newborn, usually seen in infant type A or B blood group born to mother type O blood group. Less often, the mother will be group A and the infant group B or vice versa. Although anti-A and anti-B are naturally present without a previous sensitization that is usually in form of IgM that cannot cross the placenta, but when the mother exposed to A or B antigen during the birth, ABO incompatibility, pregnancy, or abortion, leading to maternal sensitization and formation of IgM, then IgG, which cross the placenta and leading fetal hemolysis during second or next ABO incompatibility. However, some mother, usually type O blood group, has already and naturally producing anti-A or anti-B antibody of IgG type, which cross the placenta easily. That's why ABO incompatibility can occur in the first pregnancy. Although ABO incompatibility occurs in 20 to 25 of pregnancy, hemolytic disease develops in only 10% of such offspring. Clinical manifestation. Infant generally not affected at birth. Most cases are mild with jaundice as the only manifestation. Jaundice may appear in the first 24 hours or later in second, third day, or rarely develop severe jaundice. Anemia and pallor usually not present, rarely may occur in severe cases. Hepatosplenomegaly are not present or rarely mild enlargement in severe hemolysis. Hydropsychus and Carnecterus is extremely rare. Diagnosis of ABO incompatibility, usually the blood group of the mother, group O, and the baby, usually A or B. Increased TSB often the only abnormality. Hemoglobin usually normal but may be as low as 10 to 12 milligram. Coombs test or direct antiglobulin test, either weak to moderate positive or negative, with increased reticulocyte count, polychromasia, nucleated RBC, and the blood film may see microspherocytes. However, persistence of hemolytic anemia or spherocyte beyond 2 weeks should suggest alternative diagnosis such as hereditary spherocytosis. Now, subgroup incompatibility. There is subgroup as KL, C, E, W. These subgroups incompatibility also may be associated with anemia and hyperbilirubinemia. Sometimes hepatosplenomegaly, Coombs test is invariably positive. Also, sometimes may presence with hydropsychus. Exchange transfusion also may be needed sometime.